And finally, we will cover confounding. And as part of the confounding presentation, I'll also comment briefly on propensity score methods. So as commented on in the previous videos, we have random variation and we have systematic error or biases. And while we have already talked about information bias and selection bias, the more common one, the one we always discuss as epidemiologists, is of course confounding. Confounding as a term covers lack of comparability. If we compare someone and we think we are comparing them across their drug use of one drug to another, but in reality these persons are slightly older or slightly more multimorbid or something like that, we are performing a comparison that isn't really valid. And we might mix the effects. We might attribute something to their drug use, a risk or mortality increase or something that is in fact due to the underlying lack of comparability. And we have mixed those two effects together. Formally, confounding an error, systematic error, bias caused by lack of comparability between users and non-users or users of another drug. So this is the classical confounder triangle here with the example of vitamin supplements and risk of MI, the outcome. A confounder, not confounding, but a confounder is some characteristic that fulfills three different criteria. The first criteria is that it should be associated to the outcome. So this particular confounder should be a risk factor or a protective effect. It doesn't have to increase the risk of the outcome. It can also lower the risk of the outcome. But it has to be associated with the outcome. It also has to be associated with the exposure. If this is a strong risk factor, but if it's evenly distributed between the two groups we are comparing, that is, it's not associated with the exposure of interest, then there is no confounding. And I think this is one of the key things that is ultimately easy to forget, and people tend to dismiss this point that you have to adjust for all the known risk factors, which is of course true. If you have data on them, by all means do that. But in many cases, some of the risk factors might be evenly distributed and thus not really confound the association seen. But if it's both associated to the outcome and associated to the exposure, and if it is not part of the causal chain, the third requirement, you have a problem. The third requirement, being part of the causal chain, or rather not being part of the causal chain to qualify as a confounder, is best illustrated with an example. If, for instance, we say the confounder is LDL cholesterol and the exposure is statins, then and the outcome is, for instance, MI, adjusting for LDL level after treatment has been initiated will in fact be part of the causal chain. You will adjust for some of the effect of the cholesterol lowering statins, which will be measured in the now slightly lower LDL, which is part of the effect that leads from statins to a lower risk of MI, and this should not be considered a confounder. These are the three requirements. And again, the fact that it also needs to be associated or unevenly distributed between the two exposure categories is an important metric that tends to be forgotten. So to illustrate ways of handling confounding, let's consider the arbitrary hypothesis: will the use of thiazide lead to an increased risk of upper gastrointestinal bleeding? And we can easily think of many confounders if we simply compare thiazide users to thiazide non-users. Thiazide users will on average be older, a strong risk factor for upper gastrointestinal bleeding. They will also, on average, cohort level, be more frail. Thiazides are used for hypertension. This is associated to a number of risk factors that will also associate to upper gastrointestinal bleeding. So how to handle such confounding? Well, basically we can consider two different approaches to confounder handling. One would be to design your way out of it, and one would be to model or analyze your way out of it. And here's listed a few different approaches to how to handle confounding in these two categories. So I will cover not all of them, but some of them to illustrate the differences. The classical approach to handling confounding would be randomization. So if we had the thiazide users, let's by all means do an interventional study and we'll randomize people to thiazide and to not using thiazide, or for a placebo for that matter, to see whether there is an increased risk of upper gastrointestinal bleeding. There are a number of benefits, but of course also some caveats. The idea of randomization will correct not only for your known and measured confounders, but also for your unknown and unmeasured confounders. If you a year later realize, there is this very strong risk factor that we only now know affects your upper gastrointestinal bleeding risk, it wouldn't be a problem for your study, because the random allocation to treatment would have taken care of not only the things you thought of, but also unknown and unmeasured. Another consideration, of course, is that this is highly resource demanding. It is highly unethical, in particular for the study question we just listed. Looking into a safety issue doesn't really qualify for randomizing patients. It's not really efficient in small trials. You need reasonably large numbers to be sure that the random allocation will in fact average out differences between groups. But of course, the randomization is the gold standard for assessing intended effects. Another approach would be crossover design. That is, instead of randomizing to one treatment or another, say, half the patient starts that thiazide treatment, then go to placebo, or alternatively start placebo and then change into thiazide use. Crossover is almost the ultimate confounder control, since we are now comparing not only in a randomized manner, but also within individuals, and we can even with very small numbers ensure complete even distribution of characteristics. Again, this corrects unknown and unmeasured confounders, because this will take care of everything, because we are doing this direct and randomized comparison. It is highly resource demanding, and of course this is only useful with a transient effect. If the outcome or the drug affects the outcome in a delayed manner, a crossover makes no sense, since whatever you did in the first period will then affect your risk in the second period. So this only works if the effect you're looking at is immediate. Restriction. So instead of saying, we want to look at any thiazide user versus any non-users, we'll say, let's consider restricting it to a group of individuals where this allocation is more random. This could, for instance, be restricting to age ranges of relevance in terms of thiazide use. We could get rid of everyone below age 45 or 50, where the use of thiazide is, generally speaking, relatively low. It could also be restricting to people with known hypertension or users of any antihypertensive, making it much more comparable comparing these users to non-users. Of course, if you're too restrictive, we can completely get rid of confounding by age if we restrict to only 75-year-olds, but this will of course limit our statistical precision. Also, if we have enough statistical power, yet conduct our study in 70 to 75-year-olds, we will lack representativity in terms of other uses of these drugs. One could also argue that this is something that could be implemented later in the analysis, so do the sort of collect data on everyone and then later perform restricted analysis. We don't use the concept of restriction as much in pharmacoepidemiology as I think we probably should do, and I'll refer to this absolutely wonderful paper by Snevers and colleagues, Increasing Levels of Restriction, to illustrate just how powerful it is to, instead of just include everyone, restrict to the more relevant patient populations. And here they quite clearly illustrate that this is one of many ways to get closer to trial outcomes or trial estimates in your observational study. So highly recommend this paper. We can also, of course, go to the analysis part of things. That is, you collect data on everyone, but you will analyze or model your way out of confounding. A technique that is not used as much as it was is stratification. And the value or point of stratification is best illustrated with an example. Here, consider a hypothetical study, 3,000 individuals, 500 users of a drug, 2,500 non-users. There's the number of outcomes, which translates into a risk. So there is a 36% risk in the user cohort and a 16% risk in the non-user cohort, corresponding to a relative risk of 2.2. However, this is a confounded estimate because when we stratify, so we perform the same analysis but in men and women individually, we see here that there are 2,000 men and 1,000 women, and in each of these two strata, the relative risk is 2.0. This is to some slightly counterintuitive, but this is actually in fact a matter of simple and plain confounding. As evident here, you see the risk of the outcome is higher among men, irrespective of treatment, and also the likelihood of treatment, the proportion being treated, is higher among men, which qualifies then as a confounder. So male sex is here a confounder because it is associated to the outcome and it's associated to the exposure. It increases the risk of the outcome. It is more likely among male sex is more likely among users. So the confounded effect can be handled by stratifying on the potential confounder, and instead of doing analysis among everyone, do it separately and take the average effect, which here would be the correct 2.0. Stratification was historically a matter of doing what I just mentioned, but in many cases nowadays it's used in a slightly different way to specify subgroup analysis. Just as an example here, in looking at metformin and colorectal cancer risk in a study we conducted very many years ago, the overall effect was 0.8, but upon stratifying, or some might say specifying by sex, we see that there is a markedly different treatment effect in the two subgroups, which is different from the traditional use of the word stratification, which would be to conduct these analyses separately and take the average, but it is on occasion also used to denote subgroup analysis. Then we have multivariate analysis, which is probably the more prevalent approach to confounder adjustment. Here, data is fitted into a model. It could be a logistic regression, Cox regression, Poisson regression, whatever have you, to adjust for multiple variables at the same time. This can handle a very large number of variables, which is of course not quite possible, for instance, when you perform stratified analysis. There is a risk of this becoming somewhat of a black box, where you have one estimate, then you adjust for stuff, and you get another estimate. And it can at times be difficult to assess which particular covariate or what part of your adjustment actually changed your risk estimates. And there is also a risk of so-called small number bias. It can handle a large number of variables if you have the sufficient statistical power, sufficiently large data material, but there is a risk of overfitting, adding too many covariates, which I'll illustrate in a little while. So just a sort of basic example here, we are looking at risk of subarachnoid hemorrhage with use of warfarin in a case control setup, both ever use matrix and current and recent use. The crude odds ratio here is adjusted for sex, age, and calendar time, and to the conditional logistic regression, we also obtain adjusted odds ratios by adding in 12 drugs and 8 diagnoses, income, and education. So we are adding to this particular model, and as you can see here, this changes the risk estimates, however, only slightly. So this is, I would argue, the more common thing to see in epidemiological analysis. The small number bias is something to consider. However, there is also very many cases where it really doesn't matter and the fear of small number bias is exaggerated. Many will have heard the idea of you can only include one covariate into your model per 10 outcomes you see in your study. So you need 10 outcomes for each of your covariates. That is probably somewhat exaggerated, but I think it stems from a fairly old paper denoting this rule of 10, basically arguing this on the basis of not having tested anything but 2 and then 10 and then higher numbers. And in that study, it was correct that with very small numbers of outcomes per covariate, there was stability issues and systematic error in the regression. However, in most cases, it is probably feasible with only having 5, 4, 6 outcomes per covariate. If you get below that, if you have, let's say, only 2 outcomes per covariate, that is a study with 20 outcomes and you're adjusting for 40 factors. Or, I guess more commonly, a study with only 7 or 8 outcomes, but you're adjusting for 10 or 15 items, which unfortunately is seen, then you cannot really trust your model to correctly sort of estimate the underlying risk. There is both the risk of actual overfitting and a systematic error, but there is also the risk that an important confounder is only adjusted for on paper, but in your actual regression it ends up falling out, not having the adjustment effect needed. Then on to confounding by indication. This is a particularly difficult thing to handle as an epidemiologist. Confounding by indication is a specific situation with confounding where the reason to prescribe a drug is a potentially very strong determinant for the outcome in question. So this is originally coined by the Finnish epidemiologist Miettinen, and he did this study in quotation marks because this is a methodological illustration and not an actual study, to see the effect of anticoagulants. So looking at oral anticoagulants and the risk of deep vein thrombosis. The true relative risk is unknown because these drugs were initially sort of marketed during the 40s and 50s, or developed during 40s and 50s, way before we had randomized trials as a standard approach to evaluating drug efficacy. And while we now know they are highly efficacious, we would not ethically be allowed to conduct a trial. So we don't know the true relative risk, but it is absolutely below 1. And from clinical experience, we are talking way below 1. This is a very efficient drug. So perhaps in the order of 0.1 or 0.2 or 0.3. The true relative risk. In Miettinen's study, he tries to adjust for initially age and sex in the comparison of oral anticoagulants versus non-use and ends up with a relative risk of 27. So the drug that should protect against DVT is associated with a 27-fold increased risk. He also adds other risk factors for DVTs and he makes it go down until a relative risk of 4, which is of course less biased than the 27, but still quite clearly illustrates that this is not grasping at the true effect of the drug. So of course the problem here is that we aren't treating people at random with oral anticoagulants. Physicians are, as they should be, targeting those at highest risk, for instance those with a history of deep vein thrombosis or other very strong risk factors. And in that comparison we see confounding by the underlying indication for treatment, and this is very difficult to address. Miettinen concludes the confounding by indication can be very strong and it is not correctable in a non-randomized design. It's even built into the title of this seminal paper called The Need for Randomization in the Study of Intended Effects. There are many situations in which we are now able to, with modern day techniques, and when we are fortunate enough to see natural experiments happening or other factors that we can as epidemiologists leverage to investigate intended effects of drugs. But generally speaking, if you are in a situation where you have strong confounding by indication, that is the reason for giving the drug is in itself a strong confounder, this is typically something you should be very, very off as an epidemiologist. I'll illustrate the degrees of this by 4 examples with sort of increasing severity. The first would be the indication is associated with a risk factor for the outcome. This could, for instance, be statins and fracture. This is probably not even confounding by indication, this is just confounding. So use of statins is associated with obesity, for instance, or mild frailty as a risk factor for fracture risk. So standard confounding. We could also get to the part of the indication in itself is a risk factor for the outcome. This is now moving into confounding by indication territory. This could, for instance, be COGSIP versus peptic ulcer bleeding. COGSIPs and NSAIDs, class of NSAIDs, isn't of course intended to treat peptic ulcer bleeding. However, they are preferred over traditional NSAIDs for patients at an increased risk of peptic ulcer bleeding. Some of the people receiving COGSIPs might not have any risk factors, but there will be a tendency to prefer these drugs over the alternatives, specifically for people at higher risk of this side effect, even though the drug is intended to treat, of course, pain. This is difficult to address, but not impossible. Then there is the situation where the indication is a direct risk factor for the outcome. This could, for instance, be use of lithium, which is used in bipolar disorder and also to some extent augmentation of severe depression. And of course, bipolar disorder and severe depression are in itself strong risk factors for suicide and suicidal behavior. So in a study on lithium and the associations between lithium and suicide, this will be very difficult to disentangle, and most likely, regardless of what you do, you will see a markedly increased risk of suicide with lithium use. These are unfortunately all examples of studies that are already published, including this one, and this will be a very difficult thing, and probably something, even with modern day techniques, that would be too difficult to disentangle. And finally, the drug is prescribed with the sole purpose of preventing the outcome. This could, for instance, be low-dose aspirin and myocardial infarction. So we will, in most cases, not be able to, in a non-randomized observational setting, look into whether low-dose aspirin, which is given to prevent MIs, of course, to high-risk patients, whether this actually confers a protective effect. This would only be possible under very unusual circumstances if some natural experiment is happening or something else that we can leverage. But in most cases, this is a hypothesis that doesn't lend itself to observational research. Unfortunately, also something that people tend to try, even though, which typically ends up with very spurious results. So, talking about confounder adjustment, we of course also have to comment on propensity scores. So propensity scores is a technique that has gained considerable interest over the last, 2 decades or so. It's actually a technique that was developed an additional 20 years before that, but for the modern day use of propensity scores, there is a plethora of different ways to leverage this. To illustrate a clear case where propensity scores are needed, a situation that couldn't really be addressed without looking into this type of method, here is a study on the use of methylphenidate and risk of malformation. So in utero use of methylphenidate. Methylphenidate users, as you can see from the table, are compared to the background population, or that is a random sample of pregnant women. They are younger. They have a much higher rate of smoking, 51% versus 15% smoke during pregnancy, shorter education, and they have a very different drug use. 34% have antidepressant use in utero compared to only 2.8% of the random background population. With 222 exposed individuals and malformations as an outcome, we would expect a baseline malformation rate of about 3 or 4%, which should give us about 8 outcomes in total. It will not be possible to model all of these factors, age and smoking and education and all these individual drugs, against the risk of malformations, simply as the number of outcomes is way too low to address this. Instead, we use propensity score methods here, propensity score matching, and used propensity scores, which I'll explain in more detail in a little while, to identify people with similar characteristics, and ended up identifying a group of 2,200 women with, as you can see, highly similar characteristics using this method. In this comparison, these 222 exposed to unexposed, as you can see from all the measured and known confounders we entered into the propensity score model, we can perform a direct comparison, which was, by the way, some of the examples I used in a previous talk. So what is a propensity score? Well, a propensity score is a likelihood score. It's a value between 0 and 1 that, given a specific set of covariates, provides the likelihood of basically something, and in these cases being treated with drug A over drug B, or being treated with drug A over non-use of drug A. So this is just a simple likelihood that summarizes, given your particular covariate, your likelihood of receiving treatment. So in a usual regression here, a logistic regression, we would have logistic log it, logistic regression, for the outcome, given exposure and all the covariates. When estimating a propensity score, this is simply a matter of logistic regression. The outcome is now the exposure, so outcome is being exposed given all your covariates. And in Stata that I have used the most, but in most programs, it's very easy to then, once you've performed this regression, to predict the propensity score. And while this is a slightly more technical, direct approach to things than compared to the rest of these videos, I want to stress this point because it seems for people that propensity scores is a very complicated thing of estimating, but in reality it is very easy to estimate a propensity score. You would get a data set looking like this. Here's a list of individuals with different ages, sex, smoking, obesity, and NSAID use status. And we could, for instance, model here the likelihood of NSAID use, so logic NSAID, given obesity, smoking, sex, and age. And from that, you would get a propensity score value out. And here's just listed as an additional covariate. Okay, so propensity scores, they are a matter of adjusting for confounding. So we shouldn't include just everything in your propensity score, but you should go back to your understanding of what is an actual confounder. And actually, there's been a wonderful study by Brookhart et al. Sort of illustrating what type of covariates should you include. So you can conceptually think of three different covariates. There are the true confounders, such as X1, that is factors associated both with the outcome and the exposure. They should absolutely be included in your propensity score model. Then there's X2, that is only risk factors, so not confounders because they are not associated to the exposure, but they are risk factors for the outcome. And for various reasons argued beautifully in the paper, you should also include X2 in your propensity score model. Somewhat counterintuitively, for most at least, X3, that is predictors of treatment, should not be included in your propensity score model. While the propensity score is a model that should estimate the likelihood of treatment, it is easy to then think it's a matter of optimizing the prediction or predictive value of this model, but really it isn't. This is an attempt at adjusting confounding, and we should only focus on taking care of actual confounders or strong risk factors. So if anything is not a risk factor for the outcome, it's only a predictor of treatment choice. Don't include it in your propensity score. Again, this is argued in this paper by Brookhart in American Journal of Epidemiology. Once you have the propensity score, you can match, you can include it in your regression, you can stratify on the propensity score, or, and I think increasingly commonly, use weighting methods. Or you can combine the two. There is a wonderful paper by Stürmer et al. In Journal of Internal Medicine 2014 that covers these different approaches. The example I gave before was on matching, and this, I guess, was the more common method a decade ago, but increasingly weighing methods have really sort of gained grounds and is probably the methods of choice, methods plural, because there's very many different weighing approaches, the method of choice for now. So this is confounding. The main take home that people tend to forget, as I've stressed initially, is confounders are not only risk factors, they need to also be associated with your exposure. If you are living your life as a pharmacoepidemiologist, you will certainly befriend the concept of confounding and work with this almost every day.